name is Kaylee Hitz. I am a PGY1 at Vidant Medical Center. I'll be talking about the evaluation of insulin use for the treatment of hyperkalemia. There are no disclosures to share. Hyperkalemia is quite common, occurring in around 1.5% of the population. This rate increases to about 6.4% in those with renal dysfunction. The major concern with hyperkalemia is cardiac arrhythmias. There are several treatment modalities available. For cardiac stabilization, calcium is administered. To intracellularly shift potassium, insulin, albuterol, or bicarbonate can be utilized. For elimination of potassium, binders, hemodialysis, or diuresis can be used. Commonly, treatment consists of 10 units of IV insulin along with 25 grams of dextrose. Even with 25 grams of dextrose, hypoglycemia rates are still high, and the problem worsens in the presence of renal insufficiency since insulin is not cleared from the body as readily. Recent literature has suggested that hypoglycemia rates are lower if those with renal dysfunction are given lower doses of insulin in the management of hyperkalemia, evidenced by lower hypoglycemia rates when patients who have CKD receive 5 units rather than 10. The main purpose of this study was to assess the rate of hypoglycemia at Vidant Medical Center among those who received standard or full dose insulin, being 10 units, as opposed to reduced dose insulin or less than 10 units in the setting of hyperkalemia. The results may allow for a protocol to require lower doses of insulin for hyperkalemia if patients have underlying renal dysfunction. This was a single-center retrospective study that utilized electronic healthcare record reports to identify patients who received insulin for potassium shifting between August 1, 2019 and August 31, 2020. Patients were included if they were at least 18 years old and had hyperkalemia and received IV insulin for potassium shifting. Subjects must have had blood glucose values checked before and after insulin administration. If anyone received renal replacement therapy prior to serum potassium redraw or were pregnant, they were excluded from the study. The primary outcome was the difference in hypoglycemia rates between the standard and low-dose insulin groups. Secondary outcomes analyzed the rate of potassium shifting, whether hypoglycemia was increased in the presence of renal dysfunction, defined as an eGFR of less than 60, and the hospital length of stay. Chi-square test and Fisher's exact were used for nominal data analyses. Mann-Whitney-U was used to analyze nonparametric continuous data, and any p-value less than 0.05 were considered statistically significant. 1,821 subjects were screened, 840 ultimately were included, with 158 patients in the low-dose insulin group and 682 in the standard dose group. Baseline characteristics were mostly similar between groups. The weight was slightly increased in the standard dose group as compared to low dose, and I would also like to point out the average insulin doses, 5.4 units in the low dose group and 10 units in the standard dose. Of the 840 subjects, 43 did not receive any dextrose with their insulin dose. This was 9.5% of the low dose group and 4.1% of the standard dose group that did not receive any initial dextrose. This slide assesses additional interventions in percentages for management of hyperkalemia. Vidant Medical Center underwent a formulary change to implement sodium zirconium cyclosilicate in place of patiramir during the study period. Of note, the additional dextrose administrations were higher in the standard dose group than the low dose group. The overall rate of hypoglycemia in the whole population was 17%. 19.6% of patients in the low dose group and 16.4% of patients in the standard dose group had hypoglycemia, which was not statistically significant. Rates of potassium shifting between the two groups was clinically similar, being 0.2 milliequivalents per liter difference, but was statistically significant. Among patients with no CKD or AKI, so an eGFR over 60, 11% experienced hypoglycemia, whereas 18% of patients with CKD or an AKI experienced hypoglycemia, which was not statistically different. The average insulin dose was 8.25 and 9.1 respectively, and the average initial dextrose dose was 25 grams and 24.9 grams respectively. 2 of the patients in the CKD-AKI group did not receive dextrose at all. The median length of stay was about 1 day longer in the standard dose group as compared to the low dose group, which was statistically significant. As with all studies, our study comes with limitations. This study had unequal group sizes, which can cause difficulty in interpreting the results. It can be difficult to attribute all of the potassium lowering to insulin when there were other treatments administered as well. There was a higher percentage of patients in the low dose group compared to the high dose group that did not receive an initial bolus of dextrose, which could account for the slightly higher rate of hypoglycemia in this group. Overall, our study did not show a statistical difference in the rate of hypoglycemia between the standard and low-dose insulin groups. The overall rate of hypoglycemia was lower at Vidant Medical Center than what has been reported in the literature among the general population. Potassium shifting was clinically similar between the two groups. Patients with CKD or an AKI did not have a statistically different rate of hypoglycemia in comparison to the general population. A randomized control trial would ultimately be beneficial to determine if patients with any degree of kidney dysfunction would benefit from low-dose insulin as opposed to standard 10 units. I will leave you with these thoughts with regard to promoting reduced-dose insulin in patients with renal dysfunction. This practice has shown to be effective in preventing hypoglycemia in recent literature, but we did not see this at Vidant Medical Center as there was no between-group differences. 5 units of insulin provided similar potassium lowering as the standard 10 units, and a large part of protecting patient safety relies on ensuring that concomitant dextrose is given with insulin for potassium shifting. Thank you to my project advisors, Joseph Davis and Lauren Chambers.